Alert Medic 1 respond.
3, 2, 1.
You're listening to the Alert Medic 1 podcast, the premier emergency medical services podcast with your hosts Mustafa Siddiq and Ken Sanner.
Hello and welcome to the Alert Medic 1 podcast. My name is Mustafa Siddiq.
And I'm Ken Sanner.
We're really excited to meet and discuss airway management with our medical director, Dr. David Vitberg.
Good morning.
I think airway management ends up being one of those skills that we don't do as often, or we don't train as often as we should. I don't think we do it as much pre-hospital as we do other skills. And I think our skills can be really, really tested when we end up having to do the procedure.
Yeah, airway management, especially advanced airway management, even in a busy system, is one of those low frequency, high acuity skills that can really be tricky, especially if you have an anatomically difficult patient. As we were talking about before the show, when you look at the airway anatomy, it's really your roadmap for our airway management skills. And that's why we want to start off talking with Dr. Vitberg about airway anatomy today. It's very crucial to understand to have a successful practice.
This is going to be a multi-part series. We're going to start with anatomy and physiology, and then we'll go directly into, as further episodes progress, we'll talk about BLS interventions, about airway management, and then endotracheal intubation, supraglottic airway usage, and then finally surgical interventions to the airway. Doc, you want to get started with airway?
Yeah, so absolutely. So you hit the nail on the head with low frequency, high acuity. Our indications for intubation seem to be diminishing every day. So we're moving away from intubating patients in cardiac arrest. We're being told that intubation of patients across the spectrum in the field, is associated with worsened outcomes. So it's critical that we continuously learn and practice this skill. So one of the most important things with regard to anatomy I learned from my anesthesia colleagues is the concept of progressive slow visualization. So too often in the field, providers don't open up the mouth wide enough. They try to get either a video laryngoscope or a direct laryngoscope in the mouth and quickly deliver the endotracheal tube to the cords. And one of the things that I found over doing this for many years is if you pump the brakes and you just slow down a little bit and you progressively visualize the structures as you approach the glottis, the vocal cords, you're actually going to increase your confidence. You're going to increase your first pass success rates. And so let's just get into what does that mean, progressive visualization. So the first thing is you got to open up the patient's mouth widely. Okay, too often I see people inserting a laryngoscope without even doing a cross finger technique and opening the mouth. So you want to open up the mouth, and this is, of course, after you've done your assessment, your vital signs, your basic airway management. So we're kind of just jumping right into advanced airway management today. With progressive visualization, you want to slowly walk your blade down the tongue and slowly approach the glottis. So anesthesiologists will tell you first comes laryngoscopy, and then as we approach the epiglottis, we're either going to slide a curved blade into the vallecula and do indirect manipulation of the epiglottis, or take our straight blade or Miller and directly manipulate the epiglottis. And again, a fancy term for that I kind of roll my eyes at when my anesthesia colleagues talk about is epiglottoscopy. And then when we kind of get to the epiglottis, we want to either directly elevate it or indirectly elevate it. And we're going to be looking for the vocal cords, the vocal folds. And I think one of the most key pieces of anatomy for ALS providers or folks that intubate in the field to be aware of is our speed bump, the retinoid cartilage, which sits at the posterior portion of the airway. And I specifically want everybody to go pull up an image of a glottis, okay? Take a look at the retinoid cartilage, recognize those two pearly little speed bumps at the bottom of the V, the posterior portion of the airway. Now, why do I bring that up? With the advent of video laryngoscopy in particular, when people are pushing tubes either off a rigid stylet or they're delivering a tube through a channel, most of the time that tube will hit the right posterior arytenoid cartilage and it will fold into the glottis and create an obstruction. And so, we're not going to be able to right now get into all the subtle techniques about how to do that better, but you have to know the anatomy to know how to refine your intubation skill to make yourself more successful. And what I would pass along to you today is just embrace the term progressive or slow visualization of the airway structures. Take the time to slowly advance your laryngoscope or your video blade slowly down the tongue towards the vallecula, appreciate as the epiglottis comes into view, as you either directly or indirectly lift the epiglottis, visualization of the chords. And what I'll finish with is, again, with the advent of video laryngoscopy, very, very often people are over zooming. So they're rushing that process. They're not doing that progressive visualization. They're putting the lens of that camera basically either at the chords, so you're looking into this dark abyss, or worse, the esophagus. And what I find most times when I bail people out, all I'm doing is simply pulling that camera out a little bit and zooming out. So again, more emphasis on just slow visualization, progressive visualization, not rushing to get to the chords, appreciating the anatomy, becoming familiar with the anatomical landmarks that will be a hurdle, specifically that posterior retinoid cartilage.
So I definitely can appreciate what you're saying. I found in my practice as a paramedic, one of the most useful things for me is being familiar with these landmarks, because if I do go in too deep or I'm in too shallow, I can really kind of look in the airway, see where I am, figure out what I'm seeing, and then adjust my blade as necessary. What are the best ways for an EMS clinician to become familiar with these airway structures, especially if they don't see them often? What are the best ways that we can really go in and practice and get a good idea of what we're looking at if, say, real live intubations are not a super common thing for us?
Yeah, so I think there's a couple ways. So, the golden way, unfortunately, is becoming more and more difficult these days with, hospital coverage, liability, training programs, having trouble getting into the operating room. So obviously, controlled intubations in the OR setting, again, problematic because that opportunity has become fleeting, where you can actually do that slow, wide mouth opening, introduce a blade slowly, progressively visualize everything, take a little bit of time in that perfectly controlled setting with that perfectly pre-oxygenated, fasted patient to look around a little bit. After that, you're going to be managing these patients in the field. And if you can control your heart rate and slow your own procedural skill level down a little bit, you'll learn from every patient whose airway you have to manage. If you can just take a deep breath and maybe slow that procedure down by 2 to 3 seconds and take stock of what you're looking at. Next, the internet is full of media to look at, static images, YouTube videos. You just have to be careful what you're consuming there and make sure that it's, somewhat vetted and accurate material. And then there are actually more and more high fidelity airway managers coming out into sim labs. So, where we train our EMS folks here in Baltimore County and at my hospital, we have a Gamard airway trainer, we have other airway trainers that actually don't really replicate things perfectly. It's still that stiff plastic, but you still can certainly take, particularly the novice student, through recognition of basic airway structures there.
Yeah, it seems to me that cadaver labs would probably be a great resource as well, although the problem with cadaver labs, logistically, number one is getting into them, and number two, after you've done a few intubations on the cadaver, the anatomical structure is still there, but the glottic opening is wide and everything's kind of like pushed into place and kind of stiff. And I did actually want to ask you about high fidelity mannequins versus low fidelity and how well of a job they do simulating the airway, but I think you really kind of covered that.
Yeah, I think if you're looking to buy a trainer for your program, to go through kind of the checklist, national registry, I have to do steps 1, 2, 3, 4, 5, 6 to intubate somebody, you can certainly practice those on a low fidelity mannequin. If you really want to start refining your skill outside of actually operating on a real human, live human or a cadaver, there are a couple good high fidelity, specifically high fidelity airway trainers, which you can even simulate angioedema, you can puff out the lips, you can swell the tongue, you can swell the cords, you can inflate it and create bronchospasm and close the cords. So they're out there, and you don't necessarily have to buy the full body high fidelity mannequins. They actually make those hemithorax head down to the belly button high fidelity trainers that are capable of doing and simulating those things that actually have decent anatomy. But I would argue that any paramedic who intends to be intubating people has to have an experience either in an operating room or under the close supervision of a mentor or preceptor. You have to learn this skill at some point on somebody who has real flesh, real mucosal tissue. The simulators will never, ever replicate that.
I think when I train folks, not only is simulating the patient important, but also having hands-on experience with the equipment when you're not in a crucial critical setting. So, for example, when I was training a person when I was working in Cecil County, and every day we would go in and he'd have a laryngoscope in his hand, right? He'd have a bougie in his hand, because those fine movements of rotation, when you can't exactly get that bougie into the airway, or during radiolaryngoscope especially, it's not necessarily about, up and down movement, it's rotational movement, right? And you don't really get that experience unless you've played with it in a non-critical setting. Because as you said before, what's the first thing that goes when our heart rate goes up? Our fine motor skills, right?
I call it jazz hands.
Yeah, oh, absolutely.
Hands start shaking.
Yeah, and I always say jazz hands never saved anybody, right?
Yes.
And it's critical to get that training. I do. Go ahead.
So you pointed on another good little basic anatomy fact that I think deserves mention here, that I think any paramedic has to know. I would hope everybody does know, but just a reminder that tracheal rings just are anterior smooth muscles, posterior. You were talking about loss of fine motor skill when your heart rate goes up, and you mentioned the word bougie, and that specifically, if you think about that little 20, 30 degree L-shaped hockey stick, you have to hold that in your hand 100 times and understand how that really basic thing works before you put it down through somebody's vocal cords, because number one, if you don't recognize that tracheal rings are just anterior, and that little hockey stick deflection has to be directed anterior to sound the trachea and appreciate that uber fine tactile sensation of the clicks in your fingers. You're never going to hear it. I had one student tell me, I don't hear anything. Bit of remediation required there. So sounding that trachea and feeling those tracheal rings between your fingers. Again, basic anatomy that you got to know. And holding that bougie in your hand during those quiet moments in the station, laryngoscope in your left hand, bougie in your right, and just kind of rehearsing that skill, critically important.
Because I will say every mannequin I've ever trained with is fantastic at, maybe over-exaggerating the tracheal rings.
No, yeah.
But that is so good for, when it translates to either real life or even a cadaver lab, the fine feeling, right? So, Doc, as we finish up, I really want to review the actual anatomy. And I know we mentioned that it's kind of hard to visualize. We'll be attaching an image when we publish this episode. But if you don't mind, can you actually go into that progressive view as the paramedic, as the advanced life support provider introduces the laryngoscope? What are they going to be seeing both in the upper airway and as they get close to the epiglottis?
Yeah. So number one, I would be remiss without saying a good external exam has to happen first. We learn about the lemon mnemonic, looking at what do the patient's teeth look like, how big are their incisors, do they have teeth, do they have dentures, do they have any limitation in mouth opening? So you have to do a good external exam. Do they have a collar on? Whereas I'm going to have to loosen that collar to distract or open the jaw. So external exam always happens first. Then as we open the mouth widely, typically, first thing we're going to see is a tongue, big, small, everything in between. And then in our line of work, we're going to have suction available because there may be foreign bodies, there may be blood, vomitus, teeth. So suction, because we may not be able to see anything initially, and we just may have to kind of clean a soiled airway. But then let's assume that we're holding in our hand a curved Macintosh blade. As we kind of roll it into place, basically, we should be putting it in the corner of the mouth, shifting the tongue towards the left. You should be sliding that along the tongue. And then eventually, the tip of the blade should hang up in the vallecula, which sits at the conjunction of the base of the tongue and the epiglottis. And then if we get into the vallecula and we start to lift, we should be lifting up the epiglottis. And we should see the vocal cords, two pearly white strips at the deepest portion of the glottis. To the left and the right of those, you'll see vocal folds, which are kind of usually the patient has perfusion, a slightly darker red tissue. And then in a V shape, coming backwards towards the posterior structures, we should see the epiglottic folds connecting to the posterior retinoid cartilage. So those are kind of your key anatomic things that you need to be aware of. Again, epiglottises come in various shapes and sizes. They can be very small and kind of easily manipulated. They can be big and floppy, where even when you elevate with a Macintosh blade, you're still having complete occlusion and you can't see that glottis, which is where maybe a bougie comes into play. So there's going to be variations on a theme. No one airway is the same. And as the saying goes, anticipate that every airway is going to be difficult. Anticipate that every mouth opening is going to be limited. Anticipate that every tongue is going to be big and floppy. Anticipate that everybody's going to have a big floppy epiglottis and it's going to be hard to see the cords. Anticipate the airway is going to be soiled and you need suction. long story short, you've got to be prepared for the abnormal and be happy when you encounter a normal looking airway that you can get to the cords with that slow progressive visualization and get the patient intubated.
Very good. So I think that's pretty good for our first episode on airway management.
I agree. I think we had a great discussion. I'm excited for part 2 and the other upcoming parts on this topic. We want to thank everybody for listening. Please check out our website, www.alertmedic1.com. Check out our blog, see what we have. Find us on Facebook, give us a like, leave a comment if you like the show, if you have suggestions for future topics, things you want to see discussed. We love to hear it. We're on Twitter at alert_medic1. And don't forget to like, download, and subscribe to our podcast.
Yeah, we're on Spotify, SoundCloud, and iTunes. I cannot stress enough, please send your feedback. Whatever topics you want to hear, any suggestions you have for us doing better. Thank you very much for listening in. Bye for now.
You've been listening to the Alert Medic 1 podcast, the premier emergency medical services podcast with your hosts Mustafa Siddiq and Ken Sanner.